Mungkin sebelum ke pertanyaan sedikit merangkum bahwa di Thailand itu pay for performance itu mulai diperkenalkan pada tahun 2010, tetapi sebenarnya prosesnya sudah berjalan mulai tahun 1990-an. Pada awalnya adalah dengan tujuan untuk mempertahankan atau untuk retensi dokter umum itu supaya mereka tetap mau bekerja di sektor publik, yaitu dengan menambahkan insentif sebesar 10.000 baht bagi dokter atau dokter gigi dan 5.000 baht bagi farmasis jika mereka mau bekerja di sektor publik. Selain itu, saat ini di Thailand juga mereka ada Rural Area Allowance yang berkaitan dengan tingkat kesulitan atau keterjangkauan suatu daerah. Seperti mungkin di Indonesia ada daerah terpencil, ada daerah perbatasan, kepulauan, dan sebagainya. Jadi geografis itu dipertimbangkan. Kemudian juga ada sistem pembayaran yang didasarkan pada beban kerja dari tenaga kesehatan itu sendiri. Tetapi ini hanya berlaku untuk after office hour, jadi setelah jam kerja itu. Jadi di luar dari antara sekitar jam 9 sampai jam 5 itu, di luar itu akan ada insentif. Kemudian juga di pie chart itu Prof. Supasin menunjukkan bahwa proporsi dari pay for performance itu sebenarnya tidak terlalu besar dari keseluruhan pie atau expenditure untuk kesehatan suatu rumah sakit itu. Sedangkan menurut Prof. Supasin sendiri, effort atau usaha yang perlu dikeluarkan untuk mengukur indikator, untuk melakukan penilaian dan sebagainya itu justru lebih besar daripada insentif yang diberikan. Jadi ibaratnya tidak sebanding dengan usaha yang harus dikeluarkan untuk melakukan penilaian itu sendiri. Kemudian ada beberapa model ideal yang tadi dipropos, yaitu antara lain model yang lebih simpel tetapi bisa tetap memperhitungkan equity di antara dokter atau tenaga kesehatan itu sendiri dan juga efisiensi yang ingin dicapai oleh rumah sakit. Ada beberapa kesimpulan antara lain yaitu status quo yang terjadi saat ini itu sangat ingin dirubah, tetapi itu memerlukan sumber daya dan support yang besar dari keseluruhan health system. Ada beberapa keuntungan dan kerugian pay for performance itu. Salah satu keuntungannya yaitu antara lain pasien bisa mendapatkan seseorang yang menjadi case manager. Dan di sini dari hasil studi menunjukkan bahwa ada peningkatan sekitar 5% dari performa tenaga kesehatan dengan kondisi apabila ada case manager tersebut dan dengan insentif yang diberikan melalui pay for performance. Di rumah sakit sendiri juga menunjukkan bahwa pay for performance itu menunjukkan peningkatan performa rumah sakit antara 2-4% dengan pengukuran yang dilakukan selama 2 tahun.
Measurement indicators, are they all regulated by the national government or the provincial government has the authority to regulate them? Thank you.
Seems to be decentralized. Like from the first that we introduced of the no private practice allowance. So the ministry just set the national level of criteria that if doctors, including dentists and also pharmacists, not want to work in private sector, then they can ask for this allowance. But the regulations, the assessment that are they violating this contract, has to be overlooked by at the provincial level. And there are lots of criticisms. Once we went to the data collection and had a focus group discussion, and questions were raised that they already saw that doctors who signed a contract but still work in private sector, so there's no punishment at all, or no, no evaluation of this kind. So, in a sense, I think that the regulatory responsibility anyway must be decentralized or must be delegated to the lower level, which is close to the provider level. Coming to the latest criteria, or the what we call the P4P, that means the pay for item of service, pay for the performance that they perform within office hour and after office hour. The details of KPI also set by the hospital level themselves. So this is the practice. So we can see that at the hospital level, they also decentralize or delegate to the department level. So the pharmacists will have this kind of indicators. So pharmacists in this hospital may not be the same indicator as the other hospital. So it's very, very democratic, or very, speaking nicely, very democratic.
That is distributed around 1990. How much is the proportion of the non-private practice incentive compared to their basic salary, and how did it go in Thailand? I mean, how is the performance, or how did it impact the performance of service provision or any or the quality? Thank you.
Yeah, this also the as we introduced this almost it's more than 20 years. So more than 20 years. First, your question asks to what proportion of the non-private practice. So the first three parts, this blue is for doctor, and this for dentist, and this is for pharmacist. So it starts from here. This is for doctor, this is for dentist and pharmacist. So it's not very high as compared to the rest. It gained popularity or less popularity. I think it's not more than 10% of the workforce in big hospital that sign this kind of contract. And as I mentioned earlier on the information that we get from the focus group discussion, also criticisms on violating the contracts, or criticisms on it might be outdated because we have no mechanisms in improving the productivity or better quality of this. But it was our history. It was introduced before the economic crisis. And this is example of once we give something, we cannot withdraw at the end. But as our proposal is that whether we can make a new change in a simpler model, but that needs a lot of efforts.
So it only applied for hospital, not for the primary care clinics or providers.
It also for all, for primary care clinic or for the community hospital.
Oh, community hospital.
Yeah, but as you see from the source of budget, so you can see that if they work in the private, if they work in community hospital, then the government give the budget subsidy to the hospital, so it's not the burden to the hospital. But if they work in a provincial hospital, then that will be the burden of the hospital.
Usually, generally, how many health workers is in the community hospital? I mean, how many GP, how many specialists, and how many?
So it's like we have different size, like 10 beds or 10 beds, 30 beds, 60 beds. So it's from 10 beds, there can be 1 or 2 medical doctors, 1 dentist, 1 pharmacist. But for bigger size, like 100 beds, there can be 10 to 15 medical doctors and 3 to 5 dentists. So, and now we saw a reverse trend for specialist doctor. Like what we found from our research is that we had specialist dentists working at the community hospital, where at the provincial hospital there's no specialist of that dentist, because they get somewhat higher pay from different kind of this, for the hardship, for the rural area payment, and for the perhaps the non-private practice. If they don't open, then there are some question raised that how can we make specialists at the community hospital more productive?
Well, what kind of specialist is it in the community hospital?
Can be the
many,
many,
like internist, is it there? Pediatrics, BGYN also in community hospital?
For the medical specialist can be the basic one, but we may find very exceptionally some of the specialists that very advanced, that they want to be stationed there. But this is not general rule. But in general rule, we provide the basic, like the five basic group. In orthopedists, it can be the 5th one. And,
Thank you.
Yes.
Sorry, yang ingin saya tanyakan, ingin mengkonfirmasi pemahaman saya tentang pay performance itu kan lebih kepada manajemen sumber daya manusia di sebuah organisasi pelayanan kesehatan. Kemudian tadi menyebutkan yang di primary care dan hospital kan beda targetnya. Nah, kalau di Indonesia kan ada sistem kapitasi berbasis komitmen pelayanan yang di sana ada 3 indikator seperti angka kontak, kemudian program pelayanan penyakit kronis, kemudian rasio rujukan rawat jalan ke non-spesialistis. Nah, apakah memang itu juga kapitasi berbasis komitmen pelayanan itu apakah juga merupakan suatu bentuk pay for performance? Itu yang pertama. Yang kedua, saya ingin menanyakan tentang primary health card and hospital accreditation. Di Indonesia salah satu persyaratan atau kontrak dengan BPJS adalah adanya akreditasi. Apakah sistem itu ada di Thailand? Ya, terima kasih.
She wants to confirm about pay for performance because, as she knows, it's a kind of management for the health workforce. And in Indonesia, we have capitation that is based on commitment with an indicators such as the contact rates and also some other indicators. So she wants to ask, is that also a kind of P4P?
Yes, if we make the definition of P4P very broad, like the definition here, that any strategy that promote the quality improvement, or if any strategy that promote efficiency, that can be classified as P4P. This is very, very broad, and the payment to the hospital, the payment to the primary care. But if you look at the definition here in this text, in the textbook which refer to the previous slides on the definition, and we may find that 18 out of 33 countries did not report or did not find, we cannot find any interventions can be said about the increase, the P4P or the pay for performance. So it's maybe somewhat stricter criteria was made in the studying which country has or not have that P4P. But when we coming down to the level of the primary care, if the primary care in Thailand, or the or we call the ambulatory care, or the outpatient service, or the community hospital, or the performance related to capitation. Like in Thailand, we have capitation for outpatient service for the registration, and we also apply the same thing as the UK for QOF, or the Quality Outcome Framework, like how much the coverage of screening, pap smear screening, if it reach a certain level, then we give them some score, some marks, some score, and there are several kinds of indicators for this. If the overall score reach some level, then they will get a bonus payment. So if we look at it this way, the capitation is the basic, but the bonus is P4P. We also get a bonus from the accreditation of the accreditation level of the hospital. If the hospital, this is related to both outpatients and inpatient. But if the hospital get the being accredited, then they will give they will have another budget, incentive budget from the NHSO, from the SSO also. So this is a kind of making quality improvement. So, yeah, it's very broad, can be very broad. If very broad, then we may see something which may not be very, very efficient.
What is the most challenges of the P4P implementation in Thailand, and how Thailand can be overcome them? Thank you.
We try to propose a simpler model, not very complex model. The complex, yeah. So we define this as a complex model, that we had many things and many payment, and some payment may not reach the objective of retention, not reach the objective of efficiency. And there are lots of rules and regulation. And we want to have more flexibility in applying a P4P, that the hospital used to pay providers or the individual or the department within the hospital or within the health facility. But that's as we conclude that it's a very big challenge, that we need to change many things. That means we have to abolish the existing regulations, and we have to write a new regulations, and whether these new regulations will be accepted by or approved by the Ministry of Finance, who control us, or by the audit committee, which come to us and audit us. So that will be the challenge. We proposed a simple model because we can manage easily, but it may not be that easy, because looking at performance of one people can be many aspects. So it's according to what we focus on, and the people will tend to change behavior on that. But there are also many arguments that we may not reach what we want if we don't have a good control trial. But making a good control trial may be very limited in healthcare.
Sedikit menyimpulkan dari topik pay for performance, jika disimpulkan sebenarnya bisa dikatakan bahwa pay for performance khususnya untuk healthcare atau untuk rumah sakit itu sebenarnya masih kurang tidak worth untuk dilakukan, karena sistem ini bisa dibilang sangat kompleks, sehingga effort yang dilakukan akan sangat besar dengan yang mungkin tidak sebanding dengan insentif yang akan diberikan, sehingga diperlukan adanya model yang lebih simpel tetapi bisa juga dilakukan untuk mengukur indikator-indikator yang diperlukan itu. Dan Bapak Ibu, kita juga perlu memerhatikan bahwa terjadinya peningkatan suatu performa di rumah sakit atau di suatu pelayanan kesehatan mungkin perlu diperhatikan bahwa itu belum tentu karena sistem pay for performance yang dilakukan, tetapi bisa terjadi karena hal-hal lain yang terjadi. Misalkan peningkatan teknologi yang digunakan sehingga meningkatkan kemungkinan kesembuhan terhadap pasien itu bisa menjadi lebih besar. Juga bahwa dalam mengaplikasikan pay for performance itu tidak hanya perlu dipikirkan dari aspek ekonominya saja, tetapi lebih jauh perlu diperhatikan terhadap aspek kontekstual yang ada di rumah sakit tersebut. Mungkin demikian yang bisa saya sampaikan, dan mari kita berikan aplaus yang meriah untuk Prof. Supasit. Thank you so much, Prof. Supasit and Dr. Orotai, for yesterday and today's lectures.